Hello everyone, good morning. A very warm welcome to all of you. We thank you for investing your time for this webinar, and we hope this gives you more clarity about the quality payment program, the latest beast from the CMS. Now, before we begin, there are a few things that I would like you to know. As we have a limited window of time, we would be covering only the ACI component of QPP, and we'll be just brushing upon the rest of the components. If you're looking at a computer screen right now, the panel to your right has a few icons that you might find meaningful during the presentation. You can click on the hand icon in case you have a question, and we would know that there is a question that you would like to be answered, and we would address that question towards the end of that particular slide. So just be patient. If you have a question, at the beginning of the slide, we will have it answered by the time we reach the end of it. Now, on the same panel, you can click on the chat icon in your to type in your questions, and we would answer those one by one. Also, we'll share some handouts with you during the course of the presentation. You might find these handouts meaningful. Now, finally, at the end of the presentation, we'll have the floor open for Q&A. This is going to be for the questions that remain unanswered or that you could not think of during the course of the presentation. So that would be the window of time where we would address these questions one by one. Now, with that, let me clear the stage for Vijaya, our subject matter expert. She would be taking you through the rest of the webinar. So, grab some coffee, sit back, and enjoy the show. We certainly hope that this helps you plan the roadmap for the next year. All right, over to you, Vijaya.
Thank you, Amit. And good afternoon, everyone. My name is Vijaya, and I have been helping the EHRs meet the regulatory compliance and making it more meaningful for the clinicians. Welcome to the webinar today. We are primarily going to focus on the ACI component that Amit spoke about a few minutes back. So by now, many of you probably have come across QPP, which aims to provide better care, smarter spending, and healthier people. So QPP ties disparate programs like meaningful use, PQRS, and value-based modifiers, and yields to find one composite score. So with QPP, while QPP delivers high-quality care, it also rewards values and outcomes to the physicians by two parts, the advanced APMs and the MIPS. So advanced APMs, well, it's a subset of APMs where physicians can apply to specific clinical conditions or care episodes. So basically, this population which earns physician 25% of Medicare Part B payments just by seeing 20% of Medicare patients. So through the advanced APMs. Few models that fall under the APMs are CPC Plus, next generation ACOs, oncology care models, your ESDRs, and shared saving programs. So the Track 2 and Track 3 specifically. So while the risk is really high, the earnings are really more compared to the second part that we see, the merit-based incentive programs. So this is the component that we are actually going to highlight in today's webinar. Before we move ahead with MIPS, let us see what is the eligibility for the clinicians to participate in this program. So any physician who bills Medicare more than $30,000 annually and who sees more than 100 patients is eligible for this program. Additionally, MIPS eligibility is also identified by a unique TIN and an NPI combination used to assess the performance as the physician assistants, the nurse practitioners, the clinical nurse specialist, and the CRNAs. So this is the reason the participants of QPP are called as eligible clinicians and not EPs or EH. So let us take a deep dive to understand what is there in MIPS. So MIPS, as I told you, ties together 4 programs under one umbrella and gives weightage for each of this category to add up to a total composite score of 100%. Percentage, yes, the complete score is addressed with percentage. Okay, the first component that we have is advancing care information, which replaces the EHR incentive program, which is popularly known as meaningful use, and this carries a weightage of 25% under MIPS. The second component is quality. So quality replaces our PQRS, which has the highest weightage in MIPS, that is 60%. The third component, which is new to us, is improvement activities, which has a weightage of 15%. And the fourth component is cost. Okay, so we have already covered 100%. What is this cost doing here? So cost is not part of, cost actually replaces value modifiers and is not part of the transition year, that is 2017. It will be calculated from 2018. So there's no special requirements for the cost, but it will be directly pulled up from the claims that the providers are going to submit. So now let us see what is the reporting required. So the clinicians would have to report for at least 90 days in the transition year. So I'm saying this word transition year. So this is your 2017 reporting year because it is a transition to this new program called QPP. So that is the reason 2017 is called as transition year. So clinicians will be reporting for at least 90 days for next year and submit the data in the following year. Now let us go ahead and see what are the options for the clinicians. So as mentioned by CMS Acting Chief Andy Slavitt in his blog, to pick your pace in MIPS. So he has actually given us 3 options, okay? So before I start with those 3 options, if the clinicians are actually not able to send the data for 2017, the clinician is going to receive a negative 4% of payment adjustment. The first option that Andy states in his blog is called as the test pace. So by test pace, it is you have to submit something and you get a neutral or a positive payment. So by submit something, what does it mean? It means you either submit one quality measure, you submit one of the improvement activities, or you submit the measures that fall under the base score of ACI components. Okay, what is the base score measures? I'll walk you through in a few minutes. The second pace that Andy mentioned in his post is to submit for at least 90 days. So submit for 90 days and you will receive a small positive payment adjustment. And if you submit for the whole calendar year, the clinicians are going to receive a modest positive payments. So what does future hold for us is if you see, we have 4% of payment adjustment in 2019, which is gradually going to increase to 9% in 2022. So I see a question coming up from Pragati. Go ahead, Pragati.
Yeah, hi Vijaya. I have a quick question for you.
Mm-hmm.
Can clinicians reports to different 90 days period for the different category within MIPS?
Oh yes, thank you for your question, Pragati. Yes, clinicians can report to different 90 days for all these different categories. So for example, they can report to say quality measures from in the first quarter, they can report to improvement activities in the second quarter and maybe to the ACIs in the third or fourth quarter. So that is totally fine. The complete calculation is done for every component and the scoring would be done for those components. So it is not mandatory that the reporting period should be same. Does that answer your question?
Yeah, I got it. Thank you. Thank you so much, Vijaya.
Sure. Thank you, Pragati. So let's go ahead and see what is the impact of this on the EHR vendors. Okay. So just to note that what you will see now on your screen is a poll. Okay, so we have 2 polls coming up. While I catch up some breath, please go ahead and please fill in the poll. So basically, this poll is going to get accumulated, and we'll send you the results of these poll, so we better understand your needs, and next time when we come up with a new webinar, we can target your pain points. Let's get started. Let us now see what do the EHR vendors need to do. Okay, before that, let us see what the clinicians have to report. So for 2017 year, the clinicians can report using 2014 edition of Certified EHR, which is similar to our modified meaningful use stage 2, which includes 8 objectives and 11 measures. What's in 2018? So 2018 has the clinicians need to mandatorily report for 2015 edition of Certified EHR, which includes 8 objectives and 15 measures. So let us go and see, okay, what's there in 2018. So to get 2015 edition certified EHR, so we have a quick pin over here, which tells us what are the mandatory items, so what are the mandatory components for the EHRs for the clinicians to report. So the first one, as we see, is a certified EHR. So clinicians should report, can report under the quality payment program only if he is using a certified EHR. The second component we see is the EHR should have the capability to include all the base measures. Okay, the first 2 components that you see are mandatory for the clinicians to ensure that they do not fall under the negative payment adjustments. The third component, that is the performance measures and the bonus measures, are the ones that would actually earn brownie points for the clinicians. So let us dive in deep and understand what every component means. Let us start with a certified EHR. So a certified EHR definition is is our base EHR definition, what we actually had in 2014 edition. So it includes the patient information related elements, the interoperability related elements, and the intelligence related elements. So what you see new in these are implantable device list, which is a certification criterion under patient information, and the interoperability, you see the API access, which is capture and query. So we'll go in more details for API in our next slides. And the intelligence is our CDS, the clinical decision support. So how is the scoring going to happen for this? Is you have your base score. Your clinician already is using your certified EHR. Then you have a base score. You have your performance score, and then you have a bonus score. So as I already mentioned you, the performance score and the bonus score are the brownie points that completely composites the ACI score. Now let us see what are the main objectives that the EHR vendors have to report to. So the next slides that you're going to see are structured in a way that we have split them based on the modules, okay? And every measure would have a few buttons in front of them. And a blue button would mean it falls under the base score. Orange button would mean it falls under the performance score. And a green button would mean it falls under the bonus score. So let's start with interoperability. So, so for interoperability, which covers 60% of measures in MU3, and which is actually up from, I would say, 33% in 2014. So CMS is deadly serious about interoperability in 2015 edition, and most of these measures focus on interoperability. So while the base of the summary care exchange is actually unchanged, but what is new in the CCDA is a newer version called 2.1. So while the EHR vendors have to implement the newer version, they also have to make sure that it is backward compatible with the older version. So that would mean your EHR has to support both the versions, that is 1.1 and 2.1, across all the document templates, which can be your transition of care, your discharge summaries, or your referral summaries. Besides this, it also is expecting the relative changes. Okay, so a date-based search and downloading these documents at real time. So suppose if a physician wants to export these documents, say on first of every month, so the clinicians can actually configure this within the EHR and give a location where he would like the exports to be the summaries to be exported at, and after the location is chosen, on first of every month, the engine would run, and all these summary of care documents will be exported at that storage location. So when it comes to summary of care, when it comes to transition, what is another important factor is your security. So to implement the security, we have to implement direct using Edge protocol. So this is a higher level of security that CMS is expecting to ensure there is no data breach and the PHI information is secured. The second thing that you see here is the information reconciliation, which is a performance-based measure. In this, we already had the information reconciliations for the three major elements within EHR. Those were our medications, the allergies, and the problems. So what is new in this is, yes, for the established patient, you still have to incorporate for those three elements, have the support also for the newer version of CCDA. Besides this, the new thing that we have in information reconciliation is for a new patient, if a patient is referred from another physician, and so the EHR has to incorporate this new CCDA and show all the elements within the CCDA into the EHR. So this incorporation can be in two ways. Okay, the communication can be either passive or active. So by passive, it means the clinician has sent the data and it's incorporated in the EHR, similar to how we have done for the three elements. And the active would mean the clinician requests a direct transfer of CCDA, and the clinician queries and health information exchange for a CCDA. So how does this query going to happen is using the APIs. Okay, so as I told you, we'll have APIs we'll discuss about the APIs in upcoming slides. The second objective that we have is for coordination of care. So to ease the linking between the document storage and for patient health information capture, EHR should demonstrate the ability to identify the patient information. So either if it is directly received from the patient or electronically being shared by the patient. So once these documents are imported, label these documents, tag them, maybe like an advance directive, or it can be a birth plan or an insurance card. Provide more information on where to locate these specific documents or the ability to link to an external internet site. Yes, external internet site may be a cloud where the patient health information documents are stored. The next measure that we have is to enable the patient access. So, of course, we need to support the newer version of CCDA and the real-time access for view, download, and transmit. So here we are going to use the API. So what I mean by APIs is the application program interfaces. So yeah, a bit of a technical term, but these APIs would actually enable the development of new functionalities to build a bridge across the systems. So that would ease the interoperability. So building up the APIs, ONC strongly recommends to use FHIR standards. So why FHIR standards? Well, the FHIR standard is now being widely used. So say like the major EHRs have already been working with the HL7 organization to use FHIR standard for healthcare. So this FHIR standard is Fast Healthcare Interoperability Resources, which is used to exchange the data, and this exchange of data is really seamless as compared to our original standards by HL7, be it your HL7 messaging or be it your CCDA documents. So this newer version is actually using the latest technology, that is RESTful APIs, and that is the reason there's a security level of authentication also within this API, within the standard, and so is the reason that ONC recommends FHIR for the APIs. Let us move to the next one for the public health agencies. So for public health agencies, as you see, we have four measures. The first one is immunization registries, where we have, which is a performance-based, and the rest three you see are for your bonus scores. So adding more brownie points to your clinicians. For the immunization registries, the new changes are the updated implementation guide, that is version 1.5, and the support for NDC coding systems. So the support for NDC coding systems, so initially in 2014 we were already supporting the CVX coding system. So whenever the new immunizations are being sent to the registries, the NDC codes are now will have to be sent to the registries. So does that mean we have to map the CVX and NDC? Well, no, there's no mapping required. Let the historical vaccines still use the CVX codes, and let the new vaccines use the NDC codes. The next measure that we have is syndromic surveillance. So there's no major change in it for ambulatory, whereas for inpatient settings, the implementation guide is updated, and so are the coding systems. Then we see a new measure over here, that is electronic case reporting. Okay, so electronic case reporting is nothing but sending a constrained transition of care document, which is your CCDA, okay, for a complete list of patients. Okay, so maybe your list of diabetic patients, report those under to the registries, and that is your electronic case reporting. The fourth one is cancer registry reporting, which is a specialized registry. The only change that is updated is your new the newer version of implementation guide and updated versions for coding standards. Let's go to the next set of objectives, that is e-prescribing and security. So for e-prescribing in 2014, we already had the prescriptions where the physicians used to go to the portal and prescribe new medications. They can now cancel the prescriptions. They should be able to refill the new status. And yeah, the major change is also that the ERX, especially for the oral liquid medications, needs to use the metric unit standards. And the security, what is changed is use of hashing algorithm SHA-2, or actually you can also go with SHA-3, which is the latest version, but yeah, move away from SHA-1. And on the audit log, which we have already implemented in 2014, what's new is just two elements. One is user privileges, auditing them, and second is emergency access events. So while we just went through the objectives of 2015 edition, and based on a prior experience with the certifications, we have identified three major challenges that every EHR vendors will need to struggle during the implementation of 2015 edition. So let us see what are those. Okay, as you see on screen, they are CCDA, CQMs, and the new one that we have is the API access. So let's start with CCDA. With 2015 edition, CMS expects EHRs to support version 2.1, as I already told you. So few years down the line, we never know. CMS is going to say publish the newer version, say 3.1, with new templates and new sections. So that is the reason we highly recommend EHR vendors to design a scalable framework. So any new modifications in future can easily be incorporated within your EHR and with less implementation efforts. The second thing that we see here is your CQMs. So CQMs under ACI, well known. There is no requirements of CQM reporting within ACI. However, the providers will need to submit quality data for the measures specified. So CQMs is now going to fall under the quality component. So if you remember in our first screen, we had those 4 components. The first was ACI, second was quality. So yeah, quality, the CQMs is now part of quality performance category. The reporting of CQMs will be done using data captured within your certified EHR. And as you see, in 2014 edition, we actually had only 64 CQMs. And there you see, there are now 271 CQMs. So this list is going to increase, and every year, we all know that we have to update these quality measures based on the PQRS and report them. So the scoring, so every time, so annually, these are going to change, or annually, the EHRs will have to update to the newer versions of the coding systems. So what we recommend the EHR vendors is wisely choose these measures so they can fit into your requirements, the specialty base of your providers, and also the requirements that that your clinicians would choose for. So what is there in quality, what is there in CQMs is what you have to report is a minimum of 6 measures, including 1 outcome-based measures. If the outcome-based measure does not fit in your specialty, you can report for 1 high-quality measure. So the measures are categorized into the specialty-based measures also. So to ensure that your providers report to quality based on their specialty. So for example, if your providers are into oncology specialty, so you select the measures which fall under the oncology specialty sets. So besides this, yeah, all we know, the major part of CQMs were implementing those measure logics and the QRDA category 1 and category 3 files. So we have the updated implementation guide for QRDA category 1, which is the release 3. So as you know, as I'm telling you that these are going to change annually, so we again recommend you, similar to CCDA, to implement. Okay, so I see a question coming up from Mike. Hi, Mike, please go ahead.
Thank you, Vijaya. The question I have for you is, which objective does care plan fall into?
Thank you, Mike, for your question. That's a really nice question. So care plan actually has been moved out of ACI component and is now part of the improvement activities. So yes, it was part of the proposed rules, but it was under a broader care continuum. So it has been now moved from the ACI component under the improvement activities. So if your providers specialize into, say, behavioral health or mental health, or regularly use care plans for, or maybe for your chronic, maybe for their chronic patients, they can go ahead and, so you can go ahead and implement this component under implement care plan under improvement activities component. Does that answer your question?
Yes, that answers my question. Thank you.
Thank you for answering the poll. Now we know what needs to be implemented within the EHR. Let us go and see how the scoring is actually going to happen for the clinicians. So if you remember that pinpoint, we had which had the base score, the performance score, and the bonus score. So let us see which measures fall in the base score in one go. Okay, so we have these 5 measures under base score. So for 2017 reporting year, we do not have request summary of care, which is new for 2018 reporting period. So for the base score, it is all or nothing scoring. So if you report for all the measures, you get 50% of complete base score. And if you fail to report on all the measures, you get 0%, and 0% from the entire ACI category. So even if you report the performance score measures, it is not going to get counted. So you have to make sure that the base score measures are implemented and are reported. Let's go and see what is under the performance score. So here's the list of the measures in 2017. Okay, let us see what are the weightage for these measures. So there you go. We do not have weightage for except summary of care and patient-generated health data. That is because they are new in 2018. And you see out of total 9, so out of total 7, now we have send summary of care and provide patient access, which has a weightage of 20%. So that is how they have covered to a composite score of 90% for performance score. Let us have some sample data. Okay, suppose I have a clinician called Jane Doe, okay, who has reported her numerator and denominator counts. So here are her numerator and denominator counts. We do not have a numerator denominator for immunization. That's because it was a yes-no measure for us in modified meaningful use. Let us see how the scoring is going to get calculated. So here is the score for Jane Doe. If you see the second component, if you see the second one, that is VDT, okay, the base score, the score for this is 2. Okay, so since 15 falls under the second decile, the score is 2. If we go back to the first one, the score is 10. Okay, that is because 45 falls under the 5th decile. Okay, so but the weightage for this measure is 20. So the score is going to get doubled. So it is from 5 to 10. So similarly, we have the scoring for the other measures. So let us see what is her total score. Okay, well, I think she did a good job. It's 57 out of 90, not bad. Let us see what are the measures for 2018. So here is the weightage for 2018. They are flat 10 for all those 9 measures. Let us have some sample data for Jane Doe. So let us see her scoring. Okay, so if you see the first one, provide patient access, the numerator denominator is same as in 2017 reporting year, but the score is reduced. So it is because the weightage has been reduced. So it still falls under the 5th decile, but since the weightage is 10%, the score is 5. So let us see her total. It's 23. Well, I think it was tough for her to report for meaningful use stage 3. Let us go ahead and see what's in the bonus score. So bonus score, as we mentioned, it includes the public health and the clinical data registry related measures. So report any one out of these 4 and they get a flat 5% bonus point. And report improvement activities using a certified EHR and get a 10%. So that would mean a total of 15%. Let us have some sample data. So, Jane Doe has implemented syndromic surveillance. So she gets a score of 5% in 2017, and she has actually reported for syndromic surveillance and also reported improvement activities using certified EHR. So she gets a score of 15. So 15 of 15. So we covered these 3 components of of the ACIs. So now let us go and see what is the total score for Jane Doe. So we had these three components, base score. So 50, 90, and 15. The total weightage is out of 155. And here is our score. So she scored 122 out of 155 in 2017. Let us see her scoring in 2018. The weightage remains the same. And these are her scores. And this is the final score, that is 88 in 2018. So the 112 that you see in 2017 is going to get capped at 100%. So if Jane Doe had actually even had a score of 100, would also mean that she earns a total 25 in the ACI score. And for 2018, we have so I see a question coming in from Phil. So Phil, can you just give me a few seconds? I'll wrap up the slide and take up your questions. Thank you for your patience. So yeah, so for 2018, we have 88%. So 88% of 25 would mean 22. So she scored 22 in 2018 reporting year. So this is how the scoring actually gets calculated for the QPP ACI component. Now the golden question. Okay, so before I move ahead, let's have a question from Phil. Yeah, Phil, go ahead.
Hello everyone. Hi Vijaya.
Hi.
I have a question for you. Are there any exclusion for these measures?
That's a very good question. Thank you, Phil, for your question. So exclusion. So since CMS has now come up with this performance measures, they have made sure that clinicians can pick and choose the measures from these performance measures. So there are no exclusions in 2015 editions. So you choose whatever you want to report. So out of those 9 measures that we saw in performance category, they are the one they can select from. So they can get, so since the score is actually going to get capped at 100, so they can wisely choose the measures that they most frequently are going to report to. Does that answer your question?
Thanks a lot. I think I got the answer.
Thank you, Phil. So we have a poll coming up while I take some break. Okay, so as you all are seeing on screen, the golden question, what's in my future? So we have chalked out a roadmap for all of you. We would recommend that you start with the known components, that is ACI and the quality measures, which we already know, and then move ahead with the component that is improvement activities that is yet to be released. The details are yet to be released by the CMS. So start your development with the known components, and it is actually going to take at least a year for you to be completely certified and your providers to get acquainted with the 2015 edition. So we recommend that you start as soon as you can, that is early 2017. So your providers get some time to play around and get adapted to the newer version, that is 2015 edition. So where we come in, so we will be there for the whole 9 yards, from the assessment to the certification, and we can help you identify the gaps and finally get you the solution certified. We have a quick poll for you. Okay, so that's it for us from our side. Let us. So you are free now to ask any questions that you may have regarding the ACI component or any other components under QPP. So you will now see a handout coming up on your way, which will give a better picture of who we are and how we can help you get certified. Okay, thank you for your time, everyone. If you have any questions, please feel free to get back to us. You can reach out to the email, to our emails, or you can call us, and we'll get back to you as soon as possible. And yes, this presentation will be available. We'll personally be sending every one of you who has attended the webinar. Thank you for your time, and you have a great day ahead. Thank you.